Welcome to tonight's pep talk. It's our first pep of 2026, and we are kicking it off with an amazing topic and an amazing speaker tonight. So let's get into it. Tonight's topic is how ultrasound detects blood clots and how patients can advocate for themselves. We are going to introduce our guests shortly, but we want to remind everyone we are not here to provide medical advice. Please make sure you speak with your clinician directly. Because every patient, every person is unique and different. And Julie Cardoso, she is here with us this evening. She is a healthcare executive, educator, strategic advisor with extensive experience in cardiovascular and vascular imaging, actually several decades of experience. Obviously, vascular imaging, ultrasound education, and device commercialization. Julie is CEO and founder of Universal Ultrasound Diagnostics and is also very active in the medical education space as well. She has developed immersive hands-on programs that advance clinical skills, optimize workflows, enhance patient outcomes, most importantly. Julie has also led the establishment and maintenance of multiple IAC accredited programs, guided cross-functional teams in clinical and operational excellence, and has served as a key opinion leader for leading medical device and imaging companies, driving market adoption and physician engagement. Her work bridges clinical innovation, strategic leadership, and educational excellence, making her a trusted advisor for boards, healthcare institutions, and industry partners, and most importantly, for us in the patient community. So, Julie, I have had the firsthand pleasure of working with you. You joined us last year during March for Blood Clot Awareness Month during our Black Church bus tour, and you were amazing. We had a line of people waiting to see you. And so backed by popular demand, here you are this evening. So thank you for joining us.
Thank you so much for having me. I am really grateful for this opportunity to be a part of the endeavor and the great initiative of the National Blood Clot Alliance. And the one thing close to my heart, of course, is the patient. So I want to educate them as much as I can and provide them the best experience possible so they can be in a position to advocate for themselves if, God forbid, they're ever in this situation where they need.
Thank you. And then we are trying very hard also to make sure that we're giving people the tools that they can advocate for themselves. Okay, so before we get started, I'm going to turn it over to my co-host, Todd Robertson, seven-time blood clot survivor. Todd, howdy.
How you
And
doing?
I'm cold actually,
Are
here in
you?
New York, but I'm going to turn it over to you to read the poll questions and the results.
Very good. Hi, folks. And Julie, I'm so glad you're here. Wow, that was fast. Those popped up faster than ever. Here's the poll questions for you, folks. You know how this goes. There's just a couple. Just answer them, click them on if you can, and then we'll cover the results, and then we're going to have a poll at the very end as well. Question one, have you ever been diagnosed with a blood clot? Yes, a DVT. Yes, a PE. Yes, a DVT and a PE. Or none of the above. Have you ever had an ultrasound to check for a blood clot? Yes, and a clot was found. Yes, and no clot was found. No, but I've had symptoms that concerned me. No, and I've never thought I needed one. And I'm not sure if you could choose one of those. And I think we have two more. Before today, how confident were you in understanding how ultrasound is used to detect blood clots? Very confident, somewhat confident, not very confident, not at all confident. And our final question, if you suspected a blood clot, how comfortable would you feel asking for an ultrasound? Very comfortable, somewhat comfortable, unsure, somewhat uncomfortable, or very uncomfortable. So if you guys could just answer those real quick, which I know you're doing in the process, we will give you the results, and then we're going to get into our program. Really good crowd, Leslie, for just starting off the episode
Yeah, for
here.
sure. And I think people just need to scroll down. So like I miss some of the questions sometimes. So just
Yeah,
scroll
you have to
down
scroll down to get to the
and you'll
bottom
see
couple for
everything.
sure, folks. Probably should start reminding people of that when we do our polls. Let's just give those folks a chance to get their
I love seeing where
answers
everybody's
in.
coming in from across the country and even across the globe.
Across the world.
Yeah.
Yeah. So here you go. I'm going to run through these real quick for you guys. Have you ever been diagnosed with a blood clot? 23% said yes, a DVT. 15% says yes, pulmonary embolism. 34% yes, DVT and a PE.
Mm.
And 28% not applicable. Second question, and the results, have you ever had an ultrasound to check for a blood clot? 54% said yes, and a clot was found. 13% yes, and no clot was found. Only 5% said no, but I've had symptoms that concerned me. And no, I've never thought I needed one. That was at 17%. I'm not sure, 4%, not applicable, 8%. Our third question was, before today, how confident were you in understanding how an ultrasound is used to detect blood clots? Only 15% said they were very confident. 36% somewhat confident. 33% said not very confident. And 15% were not at all confident. And our final question, if you suspected a blood clot, how comfortable would you feel asking for an ultrasound? And half of you, 50%, said very comfortable. 26% somewhat comfortable. 12% unsure. 9% somewhat uncomfortable. And only 3% said very uncomfortable. So there's the results, Leslie. Interesting.
Yes, extremely. This is a topic near and dear to my heart. My diagnosis, I never got an ultrasound. I didn't know that ultrasound was used to identify blood clots. So want to make sure that everybody's getting the information they need from Julie tonight.
Yeah.
Okay, so we're going to take it back to basics. We have a multi-part question for you. So if you forget one of the pieces, just let us know and we'll circle back to it. But first and foremost, what is ultrasound? And then we want you to walk us through how ultrasound works to confirm a venous blood clot, because we're talking about venous blood clots here tonight. And is it always safe? And what are you in the machine looking for inside the vein when a provider is actually doing the exam? And then the last piece is, I mean, you know, you've been doing this for over 2 decades, but how has it evolved?
Yeah, these are loaded questions, Leslie. From the polls alone, we have a lot of work to do,
You
and
do.
it's super exciting. So yeah, these are great questions. So let me share my screen here so I can just give you some visuals of exactly of what I'm going to talk about. All right, do you all see my screen?
Yep.
All right. Well, this is ultrasound. I'm just kidding. But it's the same concept of echolocation that a bat would use to detect, food or objects, okay? So what we have here is a tool in our toolbox called a transducer. And in this transducer, we have piezoelectric elements, which are crystals that get infused with electricity and causes it to vibrate. And that vibration actually causes sound to go into our bodies and create an image. An image is going to pop up right here. And we can actually see different depths into the body. And what we're able to see is muscle, tissue, intermuscular septums, and vessels, veins, and arteries. And then on the right side of our screen, we have the display in which we can press buttons to optimize that picture that I just showed you before. So we kind of become a DJ with our ultrasound system, creating a beautiful image to tell a story about the patient that's in front of us in order for the doctor to look at to make the diagnosis. So essentially, we are artists, I like to say, creating beautiful art of the anatomy, and detectives showing whether the anatomy and physiology of the venous system is normal or abnormal. And so in order to do that, we have different tools in our toolbox. So they're called transducers. And if you look at the transducers, they're different shapes and they have different numbers on them. So the numbers, the lower the number that's on the transducer, has to do with the frequency of sound and how deep that sound wave is going into the body. So this transducer can image vessels at least 15 centimeters deep into the body, and the width of the transducer shows us a large area of the vessel that we're trying to look at. So not only can we see the vein or the artery, but we can also see the anatomical structures around it, whether it's bone, the kidney, a liver, or the spine. All right, so we can use this in the abdomen. We can use this in the lower extremity venous system, on the veins, in the legs or the arms, especially if there's a lot of swelling or the patient has lymphedema. So this transducer will allow us to image deep to see those veins. This right here tends to be the workhorse of vascular lab. We can image vessels about 5 centimeters deep into the body. And this is a smaller phase transducer that kind of gives us a specific focus of what we want to look at in the location of the body. And this can image to 15 centimeters as well, deep into the
Wow.
body. Yeah. So interestingly enough, the evolution of ultrasound started in 1945, 1950, and this is what it looked like. Now, I wasn't even a speckle in the sky in my dad's eye at this time, but this is what they had to use to get information non-invasively. So sound is not radiation. It doesn't, hurt any tissues or bones. We have a lot of testing done on this, so it's safe. And then over time, it evolved into these amazing equipment where we can see not only inside visually with black and white, but we can get hemodynamic information at the same time, which is amazing because we can see and then understand what's happening in the venous system, the blood flow at a particular location. So it's real time information. Where like X-ray, CT, they give us information over time, but it's only a couple seconds of when they actually took it. Where this is constant, non-invasive. Oh, it hurts right here. Guess what? We put the transducer right here. We can see exactly what's happening to the bone, to the tissue, and to the vessels in that area. Amazing.
When we were with you in Mississippi in March, you showed up and I was like, oh, she has her laptop with her. And it looked
Right.
like a laptop. Like that's how small it was that you were using to actually scan people's legs. It was amazing. And it's literally like bedside capability.
Absolutely, to make a diagnosis. That's why ultrasound, I believe, is underutilized in this disease state. I think that if you have the symptoms that we're going to talk about later
Mhm.
and any clinical signs, advocating for yourself to have an ultrasound is cost effective, it's inexpensive for the insurance, and it's fast and it's easy, and you can have the diagnosis, have less anxiety for sure.
And does every hospital have this?
Yeah, they should.
Or
I
urgent
mean,
care center, or where you go into like this
not
is really
urgent care
common?
centers. I mean, listen, some urgent care centers, they use point of care ultrasound where, whoever the physician or the allied health professional, PA or NP, nowadays are getting educated about using this tool to do like really focused ultrasound, like I just said before, like put the transducer down on a specific area, understand what's happening to make the diagnosis. They're not, ultrasound experts, but they understand enough to make the diagnosis. So, yes, every hospital has an ultrasound lab. Uh, some urgent care centers do. I would think where the lack is in like rural America,
Mhm.
probably less access to care, right? So they have to drive pretty far. And sometimes when they go to those clinics or urgent care, they don't have that ultrasound capability. So then they need to travel another hour and a half or so to get to that hospital to get that ultrasound.
Okay, so this is relatively easy for a clinician to use. A patient should have access to it. It's always safe, correct?
Correct.
Okay.
Right.
Okay.
And, again, the ultrasound gets placed anywhere on the body. We can put the patient in different positions, like I was showing in the presentation before. Let me just pop that back on. All right, you see that, correct?
Yes.
So again, you can see I can put the transducer anywhere on the body and put the patient in different positions. And like I was saying earlier, similar to how the Wizard of Oz introduced color to us back in the day to see things in a different perspective, that's exactly what ultrasound does for us. And so we have the real-time information that we see on our display, and that provides us blood flow, direction, and hemodynamic information, exactly where that transducer is placed on the body.
Mm-hmm. It's amazing.
So why this is amazing is because of our peripheral venous system, right? Most people are not aware that there's two systems in our body, in the upper extremity and in the lower extremity. We have a superficial venous system that's close to the surface of the skin. And Leslie, fun fact, that system is only responsible for 0 to 10% of that blood flow back to the heart, where the deep venous system is deep within the muscle compartment, further away from the closest of the surface of the skin. And you could see we have multiple veins, right, in our upper extremity and our lower extremity. And this system is responsible for approximately 90 to 95% of that blood flow back to the heart. Then, before that blood flow gets back to the heart, in the abdomen, we have larger diameter veins where all those smaller diameter veins empty into and travel to the heart. So you can see visually, if I scroll back, multiple ways the blood flow can get back to the heart, correct?
Yeah.
Where, like, Todd, you were saying you had several blood clots from your thigh to your ankle. Well, from your thigh to the ankle, you have multiple veins below your knee. You have two large veins in your thigh. You have a superficial venous system where that blood flow can bypass that blockage and get back to the heart. Where in these central veins, you could see they're big veins, but poor avenues to collateralize blood flow, right?
Right.
And so when a blood clot happens in one of these veins, it's really detrimental to the patient's quality of life, like we were talking about earlier before we got on the Zoom call. Post-thrombotic syndrome is terrible for patients that wind up with a DVT here. And oftentimes, when a patient goes and has an ultrasound, if they're symptomatic of their legs, they fail to look at these veins. And that's why some of them have a PE in concomitant with a DVT, because the blood clots are hiding in these veins and we do not look at them.
So that was one of my questions. If you go back to your previous image, popliteal. So when do you make that determination if you suspect somebody has a DVT, as an example, you're doing the ultrasound? How high up the leg do you go?
We can follow the veins all the way up into the heart, but if they were trained how to do it. So that's what the gap is right now, is the education of the sonographer who's performing the exam. There's signs and clues, like you go on a date with somebody and they say something dumb and you're like, oh, that's a red flag. There's red flags with duplex ultrasound because we have those three modalities to reference, right? So let's just say at this area, at the groin, they may not see anything within the vessel. And it's going to all come together where I can actually show you what it looks like.
Mhm.
And they'll just continue on and just say, hey, the clot's right here. But Doppler, which I'm going to show you what that looks like in a couple slides, is the original gangster of ultrasound. So before we could see inside the body, we had to listen. And that sound comes on a graph over time and velocity. And that's where the red flags are, that something is more proximal. And I'll show you in 1 second. But before we get there, the physiology of the venous system is fascinating. You all are aware that it has to do with the cyclical cycle of the respiratory phase and with the valve function. Okay. So what's really amazing about this system is its capacity to expand and contract based upon the volume of blood flow and how the blood flow is moving through these valves. These valves are positioned at 90 degrees in our veins. So it's a vortex flow bringing up towards the heart.
So
Similar
we're
to
looking
how,
at, right now we're looking at veins,
Mhm.
and then these are the valves that are allowing the blood to flow in and out.
Right, and in conjunction with the cyclical cycle
Yep.
of the respiratory phase. So it's two functions, right? So essentially, what we're seeing when we breathe, Doppler shows us those hemodynamics, like I was saying earlier. It is, oops, hold on 1 second. It's a graph of velocity over time. So this would be where a sonographer or the interpreting physician would really look and see if there's something more proximal going on where the image is taken. Does that make sense?
Yes, yes, it does. Okay.
And this is how we can manipulate the system because of the pressure. This is an artery. So you saw how the vein was being compressed and pressed down from the skin. We can't do that with an artery. We can only do that with a vein.
Okay. This is really amazing, and we really just want to impress upon people, ask for this. It is your right to actually have an ultrasound if you suspect you may have a blood clot, a DVT. So please, it's an easy test to get done. Make sure you ask for it. Todd, I'm going to turn it over to you now.
Yeah, and Julia, the only additional thing that I want to say or ask you is, and I'm saying this because I told you I'm the admin in the support group, and I manage other support groups too, and not so much in our group, but one thing that I've seen is people they worry about access. We were talking about access to the ultrasound as urgent care have them, wherever. And
Yeah.
I've seen a few conversations where people say, I bet you I can go out on eBay and buy my own, and I'll just use that and diagnose myself. Can you just say why that's a bad idea?
Yeah. I mean, I don't even know how I mean, listen, people are smart now and they can use their resources to figure it out, but I don't recommend that. You're going to drive yourself crazy.
I talk
Because
about being obsessed and getting yourself all into an anxiety
yeah,
phase. I mean, that's just not a smart thing to do, and it doesn't happen. I've never seen anybody do it, but when I see people having conversations about it, I have to step in and go, "Come on, you guys. It's just not
yeah,
going to
I
work
mean,
like
it's cheaper just to go get an ultrasound
that."
done.
Absolutely, absolutely.
You save
Okay.
yourself the headache
Yeah,
too,
yeah,
and
yeah.
stress.
Great slide. So I got some questions for you. Now we often hear about compression ultrasound, and I said we may repeat a few things, but I think these are some good questions. We often hear about compression ultrasound, Doppler ultrasound, and extended views. What's the difference between those? And we saw this in the video there too, the little snip. Why is compressing the vein so important? I hear a lot of patients going, it kind of hurts when they do that, but the compression of the vein has to happen. If you could talk about that. How does the ultrasound show whether blood is flowing normally or being blocked by the clot? Also, one of the things that people often don't realize is that ultrasound is happening in real time. Why does that matter when you are looking for a blood clot? And finally, do clots look different depending on how new or how old they are? And can you show
Yeah,
us, do you have you can show us maybe some slides on that or?
yeah. So, you're gonna have to repeat some of those questions. Those were again,
Yeah, yeah. You want me to start at the top?
so compressibility of the vein,
Okay.
again, like let's just go back to this one slide. Let me share with you because again, I understand it does hurt some patients, especially if they are positive for a blood clot. But let's remember the anatomy slide, okay? The deep veins are in the muscle compartment. They're not close to the surface of the skin. So they have to put the transducer on the surface of the skin to see that vein walls connect to each other. Because again, like I was saying earlier, we can manipulate the venous blood flow because it has to do with the respiratory phase, not the cardiac phase. So let me
Right.
just show you this image real quick again.
When we can watch that on the screen when we're having it done, it actually looks kind of cool. You really
So
learn
right
a
here,
lot
so
by that.
Yeah.
yeah, so here's the artery. I can't compress it, but the vein I can. This
Hmm.
is the blood flow right here. So the venous blood flow kind of waxes and wanes, and the artery blinks at you. So that's just giving a visual of what's happening and delineating which is artery, which is vein. But this image right here tells us exactly, specifically in that location, what's happening above where my transducer is located. So that's why a sonographer will image the entire leg, right? And the clot could maybe be at that popliteal vein. So they're able to see, okay, the location, and then they could say, what stage is this in? So in order to diagnose the staging, I'm going to skip through this slide, but actually, I think it's important to understand why DVTs occur, right? So there is a Rudolph Virchow, who came up with this triad of the 3 factors that contribute to a DVT. And we all know that it's a hypocoagulable state, which can be from a thrombophilia, Todd, like you were discussing earlier, cancer, acute post-op, pregnancy, postpartum. I know women in the infancy of the being pregnant, like the first 12 weeks, are really hypocoagulable. And then postpartum, surgery, trauma, patients that have a DVT are 50% likely to have another if they're not properly managed. Because we're going to show you visually in the next slide, the lumen of the vein is damaged. So there's trauma there. Okay, so it's already weak. And so it can have another clot form on that. And then venous stasis. Venous stasis can occur from immobility, congestive heart failure, believe it or not, venous insufficiency and varicose veins, because again, those valves are not working properly and it's pooling towards the feet, right? Causing the blood flow to stay there stagnant. Okay, so that blood not moving anywhere makes it highly susceptible to coagulate, to form together, and then obstruction. So here is what we found out with research. And research is amazing because they actually found in animal testing the clot formation. So 1 to 3 days, they found that the clot is fibrin rich, that it's really soft and mushy. And then sometimes on ultrasound, we can't even really see it. And I have really nice images to show you. But by day 21, it's collagen, okay? It looks like cement in your vein. So if you think about it, if your stories, okay, when did you begin to feel the symptoms of swelling or looking down at your legs, seeing redness, or become short of breath? Was it 3 weeks from when you flew across whatever, or were you 3 weeks post-op surgery, or 4 weeks, postpartum? There's always a story to your symptoms.
Mhm.
So technically, most of the time, the patients we see in our lab, okay, they'll come in around day 15, day 21, because there has to be a lot of clot in the vein in order for you to become symptomatic. That vein is in the muscle. So what happens is that vein is no more pliable. That clot is sticking to that wall, expanding that vein, that's causing pressure on that muscle. That muscle is getting closer to your skin, and at your skin level, that's where all your sensory and nerves are for you to feel it. Does that make
Right.
sense?
Yeah, it
Yes,
does.
what a great way to explain it.
Yeah, so it's the amount of clot burden that makes you symptomatic. So you can have a little clot in that popliteal vein, but you may not feel it until day 21. And now it's all the way up close to your heart. And now you can't breathe. So it's
Mhm.
really, that's why I said the venous system is fascinating. And that's why pulmonary embolism is the 3rd largest killer,
Right.
because we don't feel it to this far out. And by this far out, it's collagen. So most of the time, anticoagulation is never going to get rid of the cement. And that's why patients who have DVTs are highly susceptible to have another one, because this clot does not dissolve. Only this fibrin-rich clot does. So let me show you an example. So this is what we see on ultrasound. So here's my transducer. Here's the skin. About 2 centimeters, 2¼ centimeters. This is my femoral vein anterior wall. So that's the beginning of it. And right here at 3½ centimeters is the bottom of it. And from here all the way to here is a clot. Now you can see the different colors of gray shades, can you? Not, right? So you can see how this is more bright white and it's sticking to the wall. This is exactly what we're seeing, this cement type clot at 21 days. That's what this is. Where this fibrin rich clot, you see how it's very black and a mixture of gray, and it's free floating. It's not attached to the wall right there. And then you could see this white stuff rushing up towards the heart. So this way is your feet down here and your head's up here, and this blood is flowing towards your heart. And so then you can understand how a pulmonary embolism occurs.
Mhm.
So it's clot begetting clot, at different stages, and the amount of clot causes you to become symptomatic. Because here's your surface of the skin. This is where all the nerve endings are. So this gets dilated, pressing everything up. You're beginning to feel a little achy or pain. Your wife or spouse is saying, your leg is swollen, or you're like, hey, I'm having muscle cramps. Can you rub my leg? So all these things you don't think, right? But you never know. So that's why ultrasound, it's like just, hey doc, I'm having some aching and swelling. You know, I would like to get a duplex ultrasound just to make sure everything's okay, especially if you have a story, if you were traveling, if you have a family history of DVTs or PEs. Like these are all signs for you to just, if you see it, if you're swollen, especially if it's one side versus the other, please go get an ultrasound because timing is everything. Because remember, anticoagulation is not going to work on the cement. It's only going to dissolve this. And this cement is why you have post-thrombotic syndrome, right? Your quality of life with the swelling and the aching. Todd, you could share your story with those on today. It's brutal, but you found a way to deal with it.
Well, and thank God for collateral veins and all that rerouting that was going on. Because when you think that I have a clot from ankle to thigh, I mean that sounds horrible, and it sounds weird to say I have no complaints because of that rerouting of the blood. It reduced the swelling so much to where only when I have a PTS flare up do I even feel anything, right? But there comes a point, and one of the questions, it's like I've had people ask me, okay, you've had that clot now for a year in different places, can't they go in and just take it out? Right? What do you say to that when people go,
Yeah.
can you take
Well,
my old clots out?
yes, we can, but we are getting all the data. Industry's doing a great job. I mean, man, we have the amazing tools and even better ones coming on the market, but we need data to make changes on how they treat patients.
Hmm.
So that's what really pushes the needle. But yes, there are treatments to get those veins, that cement out of your vein. And there's been great outcomes. And I believe we're about 7 years. We have 7 years almost of data
Yeah.
from the inflammation of the device to them doing all these trials. So it's a really great time if you have a DVT to have a DVT because now you have options where 10 years ago you didn't, right?
Right.
So there's options and there's great providers out there that are really skilled to do these procedures.
And
And
like,
just
so my
to,
vascular specialist, who's also a surgeon, said, we could try something like that, but your symptoms aren't severe. They're not even really bad. So it's like you could jeopardize maybe even making things worse in a way, right? When you start working on all those veins. I mean, there's no guarantees that I'm going to be better than I am now if I let something like that happen. So I chose to, I'm just going to let it hang. I'm doing okay. I think that was the
Yeah,
better choice.
yeah. I mean, I think case by case is appropriate to say right
Yeah.
here. I'm not a physician and, everybody's stories tailored, anyway, I think the point is there's treatment tailored to you,
Yep.
right?
Yep. There
Like
is.
that, there are options for you. And if the benefits outweigh the risk, go for it, right?
Yeah, and I,
So,
I don't think you answered this. The last question was, do clots look different depending on how new and old they are? Can you
yes,
tell an old clot
that
from a new
that's what
clot?
well, that's what
yes,
that
so
is.
that's what
Okay.
this is.
Yeah.
Okay.
So this is older clot, right?
Hmm.
And this is newer clot. So what's really fascinating when this data came out with this animal research, I was like, oh my God, this is exactly what I see on ultrasound. Like how
Mhm.
amazing. Like it's like, but you don't know how to articulate it, but then science figured it out. It's like, yes, we know that cement doesn't go anywhere. And I see that new clot forming. So yeah, they prove clot begets clot and that there's a time to it.
So just
And
to make sure that everybody knows the terminology. So when we refer to PTS, we're talking about post-thrombotic syndrome. And what that is you can have after effects of your DVT, which can result in continued swelling or pain or redness. And it has many different symptoms associated with it. The longer you go undiagnosed, potentially the worse it is because that clot can become hard. And then you potentially end up with a situation where part of it is with you for a long period of time, possibly forever. However, now there is new technology coming out that might actually help alleviate that. That's correct?
Correct.
Okay.
Right.
Okay. So this is amazing. I have never seen Clot and then the continuation to old Clot. So this is another reason why you need to ask for ultrasound if you think you have a DVT, because you need to get this addressed sooner rather than later, so you don't end up in this situation with an old clot in your leg and run the risk of a piece breaking off and becoming a pulmonary embolism. Okay, let's talk about self-advocacy, because Julie, you're like the queen of self-advocacy, which is one of the reasons why we have you on here tonight. So now
Okay.
knowing how ultrasound works, what should patients understand or ask specifically? We should actually come up with a handout for people during an exam to make sure it's done thoroughly and correctly, because not everybody is Julie Cardoso and we're not going to have access to you. So what should they be asking in order to make sure they're getting this done correctly and fast? And then the second part is sometimes patients are told they don't have a clot when in fact it's been missed. How does this even happen? How can it be missed? Symptoms matter. If someone still suspects that they do have a clot, what should they do? As an expert in the space, what would you like to say to our audience about this tonight?
Yeah. So I believe that you are the only one that knows how your car is running, right? And the more you articulate your symptoms to your doctor, the more he's going to have alarms ring off in their heads of what to do with you. They are not mind readers. They are moving through their day, triaging and diagnosing patients. And even in the ED, they're looking at you, and I know you're scared and you don't even know what to say, but you have to describe exactly how you are feeling, how your car is running to the best of your ability so they can understand what's happening. And if they do not do a duplex ultrasound, or say they get blood work and said and say, hey, listen, I'd really like to have a duplex ultrasound before I leave, just so I can have peace of mind. Will you please,
Mhm.
put that order in for me? Okay. I mean, at the end of the day, you're paying for it, right? So it doesn't hurt to ask. And if they still like shush you away, ask for the head charge nurse or somebody else and just say, hey, listen, I don't want to cause any trouble, but I really do not want to leave here until I have an ultrasound, knowing that I do not have a blood clot in my leg because of my family history. So, education is being out there in the field. I know, Leslie, you and I and Todd and Taryn had talked about this before we went on. When we thought we've already done so much, and you think about all that industry's done, we still haven't done enough, right?
Right.
There's still providers that are not even knowledgeable about clot staging and about anticoagulation and thrombectomy devices and all these avenues of where clot can be missed, especially in these big veins in our abdomen. Sonographers don't even know to look there. Okay, so we have so much work to do. So it would be helpful for you as the patient to understand the limitations, because there's limitations everywhere, right? Your hairdresser has
But
limitations.
how does it get missed at times? Why does it get missed?
Um,
We get this a lot.
well, yeah, so it gets missed because it depends on what the Doppler's showing them. It depends upon what the settings are on, right? So a lot of it is just going through the motion of the day, following a protocol, and not really paying attention to the information that's in front of them. And the interpreting physician, whoever they may be, sometimes are just roaming, clicking through images, 100 of them in 5 minutes, and they can miss it.
Okay, so
So
this is why it's really important to know those signs and symptoms. I know you and I talk about this a lot, signs and symptoms, because if you're turned away and you still have those signs and symptoms, as you say, you know your car, you're the best, you know your own body the best, go back or go someplace else and get another
right. So
ultrasound.
that was the other thing we were telling on the tour. Like, okay, if they don't give you an ultrasound, you can choose where you want to go. Go somewhere else. Like if that were me, I'm not going to stop until somebody looks at my veins. This is my life, and I have to advocate for myself, right? And again, it takes courage to do that, and it is scary, but there's freedom in that too, because at the end of the day, did I do everything I needed to do to help myself, right?
Good point. Todd.
So to follow up with that, let's talk about patient-specific factors, how is ultrasound quality affected? Is it affected by things like if they're massively swollen, um, lots of pain, obesity, recent trauma, surgery, if they have a cast on, a wound, even pregnancy? How does those factors affect an ultrasound, the quality of it?
Yeah, so again, that's why we have those different tools in the toolbox, those transducers I was showing you. So we have different frequencies to look deep into the body where they're swollen. Also, sound. Sound travels fast through muscle and blood, soft tissue, and not through bone. So those positions that I was showing you earlier, okay, is
Mhm.
how we can answer the clinical question. It's not always going to be pretty for us to see, but we can say yes or no, and the stage it's in for sure. Um, but again, education is the key for the person performing the exam. Education is the key for the person interpreting the exam. Because
Mhm.
I can do a great job with my ultrasound, but if the doctor who's reading it has no idea what he's looking at, what good does it do the patient?
Right. You have all that
So,
excellent technology right there, but you
right?
have to know. But we are blessed to have that technology. That is for sure, because it's certainly saved my butt a couple of times.
Does
So
obesity skew the results? Does it make it harder for you to read the ultrasound?
Well, again, it has to do with where you're placing your transducer and the information you're getting. And
Hmm.
again, as sonographers, we put the patient in different positions. So, for instance, if the patient is 9 months pregnant, okay, 10 months pregnant, or has a high BMR and a pannus, right? I'm not going to lay the patient on their back and image through their belly. You know what
Right.
I mean? There's
Yeah.
15 centimeters of amniotic fluid or adipose fat. I'm going to turn them on their side and image through their kidney, which is an organ where sound waves are going to travel quickly. And right under the kidney is that inferior vena cava, depending upon what side I lay the patient on. So again, as a sonographer, we're essentially an artist, right? So
Right.
we're telling a story about the patient based upon the symptoms you're telling me. So I want you to tell me how your car is running. So I know how to put you in different positions, how to get the picture I need to prove the point that you have a blood clot.
Interesting.
Also,
Okay.
look for a lab that is IAC accredited in peripheral venous testing. Can
Which
I
stands
tell
for
you?
what?
IAC, so basically, the IAC is an accreditation body that provides guidelines, and these labs have to submit positive cases. So patients that have DVT, and the physician has to interpret them correctly in order to obtain this accreditation. Now, only 2,000 labs are accredited in peripheral venous.
Hmm.
So look up an IAC accredited lab in your area and go to them. So one, go to a lab who's accredited, guarantee they're not going to miss your clot. Advocate for yourself, know the signs and symptoms, um, swelling, warmth, discoloration, severe pain, swelling on the foot. Remember cramping, okay? Don't have your spouse or friend rub it because again, you can
Yeah, people
manipulate
crank a
that
lot.
venous
Yeah.
system.
Okay. Come back to the pregnancy for a minute because we've had a lot of women that have experienced blood clots during pregnancy. And not just during pregnancy, but for up to 3 months post pregnancy as well. So when you do suspect the clot in a pregnant woman, um, is the ultrasound more extensive than a standard leg ultrasound? Are you scanning over a greater period on their or area on their leg? It's kind of my questions about the popliteal vein earlier, like how high up do you go to make sure that you're identifying clot?
Yeah, so let me just show you. So in a pregnant woman that comes in either pregnant or postpartum, I'm always looking at those central veins, okay? Because
Okay.
one, those central veins, remember, 90 to 95% of that blood flow is going through those diameters, two on each side and then one large one in the center. And when that uterus grows, it's pressing on those veins. So again, you have stasis and hypocoagulability. So that patient already is in the triad, right? So I want to make sure one, below her abdomen, all those veins that I showed you earlier
Mhm.
are compressing and that the blood is flowing cyclical to what I'm seeing with the respiratory phases. And then in our abdomen, I'm going to look at those central veins to ensure that blood flow is moving to our heart properly. Or, okay. So again, if you look here, we have different areas where we put the transducer, and notice that I'm using two different types of
Yeah.
transducers. So I always tell sonographers, use the tools in your toolbox, put the patient in different positions, right? So you could see this patient's postpartum, okay? So she still has a little bit of an abdomen. I'm looking above her groin area where the hip bone is, right? Because I can't see through bone, sound doesn't penetrate. So I want to image through muscle. So the iliacus muscle is here. So I'm imaging through that muscle to look at the veins. And then imaging through her kidney here to look at the inferior vena cava, the largest vein, bringing the most of that blood flow to the heart. And I can move my transducer and shoot down to look down towards her leg, or shoot up to look at her heart. So I can see the entire whole veins that I show you on the diagram, which is rocking. Okay. But again, these are skilled techniques that are learned and taught from a mentor. And I still have a lot of work to do, Leslie.
Don't we all? Somebody mentioned in the chat just now, and we want to get to the questions shortly, but fibroids, because this was actually a topic that came up after my blood clot, because I'm unprovoked, they weren't sure what it was, and I was diagnosed with fibroids, and they actually said you can get a blood clot from fibroids. So how do you engage ultrasound with that as well? You see them,
Yeah, so especially if it's a sonographer who is, an expert in imaging the uterus, those fibroids, again, they're the perauterine system, okay, is highly vasculature. So you have tons of
Mhm.
veins around there. So if there's a fibroid there, it's causing a compression on a vein, and the body is building multiple collaterals to get that blood flow around it and up. So again, you have that stasis, and you have stasis and compression together. So that's why you're highly susceptible for a clot. And then if you have a thrombophilia, then you have everything. So it's that's why it doesn't discriminate, right? It doesn't.
Totally.
It can happen to anybody, and that's what's so scary. But it's also, the more aware you are, it's not to get paranoid, but to understand the why, I think, is freeing.
Yeah.
And the
And
mechanism.
knowledge is power for sure.
Yeah,
Todd?
the mechanism, the why, and that, there is multiple ways to collateralize, and why patients don't feel it right away. And for instance, like if somebody has pelvic congestion syndrome, they're highly symptomatic, but they don't have a clot, but they have other issues. So
Yeah.
it's just, the more we're understanding, because we're seeing, because technology has advanced so much, that now we can make those diagnoses and really help people.
Yeah. No, this is great. Todd?
It's something I've seen a lot in the last couple of years since I've been paying a lot of attention, but basketball players, golfers, drummers in rock bands, baseball pitchers, they've been getting, blood clots in the arms and in the shoulders. So when it comes to the ultrasounds, pretty much the same process, right? To do the arms, neck,
Mhm.
groin, same process, looking at the veins. Um, do you find that have you come across a lot of arm blood clots in the shoulder?
Oh yeah. Oh yeah,
Mm.
because there's a natural compression of the rib
Yeah.
space, compressing a larger vein that goes to your heart and up here by your clavicle. So again, you got to think that 95% of the blood flow trying to get up, there's that bone compressing the vein, right? So
Mhm.
the arm is going to swell, it's going to cause stasis, and that's how the clot happens. And this is a natural variant, right? But not
Mhm.
everybody is, again, it's not discriminatory. It doesn't discriminate. It can happen to anybody. But like I said, the why and the how, I
Right.
think, is really powerful.
What is the risk for not catching a blood clot in the arm? Where does that blood clot go? Is it going to break free like it does in the deep veins of the legs?
Yeah, because your arm is deep veins. You have both
Okay.
systems. You have veins that are close to the surface of the skin, which is the superficial, and then you have those deep veins that are in the muscle. So all those veins lead to the lung. And so,
Okay.
yeah, those patients have pulmonary embolisms too.
Yeah.
So you can have a clot anywhere and it
Sure.
lead to a PE.
But
Okay.
ultrasound should be able to identify it if it's done correctly.
Absolutely, 100%. It's the gold
Mhm.
standard.
Okay, great. All right. We have a lot of questions and it's 7:53, so let's get to it. This is our favorite part, the Q&A. And we've got a lot of questions in the chat also that we want to get to. So I'm going to kick it off, Todd, with a few questions, and then you and I can bounce back and forth with Julie.
Yep.
So how do I manage a blood clot after a year and there is scarring? Which is a great question, which I think gets back to what you were showing, that image of live clot, old clot.
Yeah. So as far as management, that's up to the individual's provider, but I do know patients that have old clot, we'll call it, use compression and lymphatic pumps to help, you know, get that blood flow back up to the heart. They'll wear compression every day. I mean, we've come so long of a way with compression garments. It's amazing. Strongly recommend compression that is medical grade and not Amazon. Medical grade compression has a standard that they need to adhere to in
Yeah.
order to sell into the market. So it's maybe expensive, and thank God insurance companies are now paying for it. But it's worth it because this is going to last you, where the Amazon and whatever you order on the internet is not medical grade. It's not graded compression, and what you need is particularly, especially of a blood clot. And you maybe get one use out of it and you don't even know if it's going to help you or not. So do your research, search for companies that are medical grade, and again, check with your insurance company and wear compression. See if your physician can get you a pneumatic pump where you can lay down and get your legs and your lymphatic system moving to get
Moving.
that blood flow up to the
Yeah.
heart. And consistency is key.
That's great. We
Consistency.
actually in July we have an annual compression pep talk. So if Taryn can, she can put the link up for everybody so they can watch. And it's a vascular doctor that works with us, and it's a incredible resource to learn about compression. And you're right, not all compression is created the same. I'm going to throw one more question out and to you, which is, should patients who have had DVTs get yearly ultrasounds to rule out more clots?
Well, again, there's different schools of thoughts, right? And it really depends upon your provider's education on what he'll or he or she will say. Okay. Now, if it was myself, yes, I would be getting an ultrasound, especially if I wasn't on any anticoagulation. Absolutely.
Okay.
Okay. But again, it's an individual for the provider to make that decision.
Okay. Todd?
From the question box here, I had a PE and no DVT was found in my legs. Should I have asked them to look in my arms or abdomen to see if there were any clots there or seen any damage? Should they have done that?
Yes, they should have looked at your central veins. So most facilities are going by the chest guidelines, what are saying every patient that comes in with a PE should be scanned for a concomitant DVT. Okay, so thankfully those guidelines are being instituted throughout our nation and we're following them, thank goodness. But not everybody's looking at the central veins, right? So yes, if that were me, yes, please look at my central veins to ensure that there's no clot there. And interestingly enough, I was on a training session with a hospital organization, and the patient had came in 2 days before I got there to do my training for lower extremity DVT. It was negative. Patient came back when I happened to be there. The symptoms were worse. Lower extremity venous system, normal. Blood clot right there, 3 inches away from their heart.
Wow.
Okay. Massive clot. And then if that clot would have dislodged, that patient would have never made it. So thank goodness that patient came back. So
Wow.
definitely advocate for yourself to have them image your central veins. They will get reimbursed for it. If they don't know how to do it, you ask for somebody that knows how to do it.
Excellent
Or if they
advice.
send you for a CT. I mean, listen, at the end of the day, every patient that has a PE gets a CT. The CT should be picking up that
Mhm.
clot in the central vein if the ultrasound misses it.
So they should be looking for it, but if they don't, you can certainly say, hey, can you make sure you check those central veins?
Yes, and
Absolutely.
ask
That's
the
being your own
doctor.
advocate. Ask,
Right,
yeah,
ask the doctor, hey, was there any clot in my central veins in my, that vein that goes to my heart?
right, right.
Mm.
Okay, another question. If you experience leg swelling from a flight, say 2 or 3 months ago, without
Mhm.
any other symptoms, should you request an ultrasound now if you're worried about it?
100%.
Okay.
Especially if you don't have any history of diabetes, heart failure, you're young, right?
Hmm. Hmm.
Absolutely, 100%.
Great. Leslie?
Um, do varicose veins mean that I am more susceptible to a DVT?
Well, varicose veins are considered venous insufficiency and puts you in the triad called stasis, where again, those vein valves are not closing, so it's causing bidirectional blood flow to pool down towards your feet. Now, are you going to have a clot? I don't know, but you are in the triad. So if I had varicose veins, I would be wearing compression every day.
Okay. And I know everybody needs to speak to their own doctor, but I think this is a really interesting question. If your ultrasound shows calcified residual clot above the knee, should a filter be considered? Is that something that I should discuss with my vascular doctor?
Yeah, I mean, listen, it's everybody's theory and how they were trained and where their education is at, right? Again, we have so much data where those thoughts are being changed. So I recommend, seeking and doing your internet search to find somebody who is up to standard with everything that's happening in the
Yeah.
venous space and have a consult with them and get their opinion.
Okay. Todd?
Can an old DVT from, say, early in 2024 still break off and travel?
That's a great question. Anything could happen. Okay, anything could happen. But the scary thing about old clot, again, you're in that triad. That wall is damaged. Okay, so will it break off and cause more clot? I know that more clot will form. So whatever breaks off is new clot that formed
Is new clot,
and
right?
dislodged. Does
Okay.
that make sense?
Yep, that
Because
makes
that's
sense.
that spongy material that we saw on that ultrasound image.
Yeah, yeah, excellent answer. Now I know when I go in for ultrasounds, they've never moved the screen out of the way. I've always been able to watch, but a question from Q&A is, do you know why they used to let the patient watch the ultrasound, but they seem to no longer do that? In my experience with many ultrasounds in multiple locations, including Mayo Clinic, that they don't let them watch that. Does this differ from location to location, hospital to hospital?
Yeah, it's really site specific,
Okay,
honestly. I mean, at the end of the day, as a sonographer, we're not allowed to tell you the diagnostics.
right.
When my patients come, I give them a great experience and I'm really honest with them. I say, hey, listen, I'm not a physician. Legally, I'm not allowed to tell you your diagnosis, but all I can say is that you're in great hands. I'm a great
Mhm.
photographer, and we're gonna get you where you need to be as quickly as you need to be there.
Right.
That's really all I can say. Otherwise, they could take everything from me and it's sad, but
Yeah,
we're not, legally, there's tremendous consequences
that's right.
if we go out of our scope of practice. I'm an expert in ultrasound. I'm an expert in what I do.
Mhm.
Um, yes, I can interpret what I see, but legally I'm not allowed to tell you.
Everybody's got their specialty and they need to stick with that specialty, and that's what they're good at.
Exactly.
So,
Yeah,
okay. Leslie?
Well, that's why time to diagnosis is so important.
Yeah,
correct.
Time to diagnosis. And we need to be pushing the clinical community more and more time to diagnosis. You go to the emergency room, you go wherever you're getting your scans done, ultrasound done, time to diagnosis. It needs to be faster because that will alleviate a lot of long-term complications for people as
mhm.
Right.
well.
And more reason for them to go get it checked as soon as possible when you start having symptoms.
Okay.
Nobody
Um,
knows their car like you do.
exactly. Okay, this is actually from one of our patients who's in New Zealand. I was diagnosed with a clot last year and had to go to the doctor twice before they grudgingly referred me for a scan and was diagnosed with a calf DVT. Since that initial diagnosis, they have put me on thinners and told me it's not necessary to get scanned again. Now I have the same pain in my other leg, and wish it was much easier to book a scan. Wondering if a Doppler scan is as effective as an ultrasound in diagnosing clots below the knee.
So Doppler and ultrasound are okay. So Doppler meaning just the waveform that we see? Yes, because if the blood is blocked in the calf veins, you could see it with Doppler on your display. You can hear it. Okay, you can
Yep.
hear it. Um, but usually ultrasound, or when you go get an ultrasound, they do both. So I'm not sure what the practice is out in New Zealand, and I'm surprised that you can't get one readily.
Yeah,
Mm.
I think it's different from location to location.
Yeah, but absolutely a Doppler can tell you the flow in your calf veins, 100%.
Okay. Do DVTs occur more often in the left leg than the right?
Ah, great question. So, interestingly enough, there's actually a study that's published where there's a normal variation, right, of our anatomy, of how we were developed, right? So the inferior vena cava is to the right of our spine, and it has to cross over the fifth vertebrae underneath the right common iliac artery to the left leg. So it has to go a longer distance to go to the
Mm.
left leg, and also it's between two structures that it causes compression with.
Uh,
So compression, diameter reduction of those large veins that I showed you in our abdomen can occur in 34% of the population. That in conjunction, like that's going to put you in that stasis category of the triad. So if you have a hypocoagulability state and a trauma to any of those
yeah.
symptoms we showed you, then yes, left leg is more susceptible. But we also are understanding that this type of compression can be anywhere in these central veins. So anywhere there's a diameter reduction can be susceptible to blood not moving properly, okay? Because it's pooling here and it's got to get that massive amount of blood flow through that narrowing.
Okay. I'm gonna throw one more out and then Todd, I'm gonna let you take the last two before we
Okay.
call it a night and do
Yeah.
our poll questions. Um, can ultrasound be used to identify May-Thurner syndrome? Does it detect clots and does it have any limitations in terms of visualization?
Yeah, so absolutely 100%. And that's what we were talking about. Why are DVTs on the left side more than the right? May-Thurner is the term that they call it. That's that normal variation of the IVC going over the fifth vertebrae to form the iliac vein on the left
Mhm.
side and being compressed. So that's essentially, Todd, what happens up here, Hatton-Schroeder syndrome. Okay, it's a normal compression that causes a clot. Same concept, except in the abdomen and affects the left side of the leg.
Mhm.
Absolutely can be diagnosed with ultrasound. Again, sonographer education, sonographer training. Yes, those tools in our toolbox, we can definitely make the diagnosis 100%. And it matches what they see in the interventional suites called IVUS. It's intravascular ultrasound, where they actually put a crystal on a catheter, put it through the vein, and are able to see the diameter differences. And that's where they
Hmm.
officially make the diagnosis of May-Thurner, because they have two references to go by. And then they will figure out, best course of action for that patient, okay,
Right.
based upon the individual factors.
Amazing. Okay, great
It's
information.
absolutely amazing. I mean, 10 years ago,
Yeah.
we couldn't do this.
Yeah.
Right.
So
And it's just
it's
going to get
awesome.
better and better and better. And again, hopefully time to diagnosis is faster and faster.
Yeah,
Right.
so again, if they don't have a sonographer that's has that capability of doing that exam, they usually send patients for CT to
Oh,
diagnose that.
yeah, right. Okay.
Yeah, it's good that people know about May-Thurner. They need to ask about that. They need to talk
Yes.
to their doctor about it because you don't hear a lot about it just talking to people unless a patient's had it. Two easy questions, and then we'll get to our poll questions. So someone's just asking in the Q&A, would it be my hematologist that I talk to if I have questions about older ultrasounds?
older ultrasounds?
Yeah, ultrasound results. Would my
You
hemo
can
have
review them.
results, and I'd be
Yeah,
able to
yeah.
ask them
Oh,
questions about that?
absolutely. Yeah, they should be knowledgeable of reading the results to you 100%. Hematology actually has the knowledge of thrombophilia and staging.
Okay.
I hope so.
And
Yeah.
they'd
They
have access to
should.
those anyway.
Yeah,
Are the ultrasound services covered by Medicare?
100%. If
100%.
you're a Medicare patient, yes.
Yeah. Okay.
Yeah. Important. Good to know.
And listen, you could pay cash. I mean, at the end of the day, if you need a service and you don't have insurance, there's always a way. And
Right.
nobody's gonna ever turn you down for care.
Right. Yeah. Kind of like that with colonoscopies nowadays, right? If you can't afford it, you don't have insurance. There are places that do free colonoscopies because they're so important. And ultrasounds are the same way. They're very important to get under. We'll go
Okay.
ahead and do poll questions, Leslie.
Yes,
All right.
absolutely.
Let those pop up, and I'm going to read some poll questions here, closing questions for you folks. If you could answer them, then we're going to let you go and get on with your evening. After this session, how confident are you in understanding how ultrasound detects blood clots? Very confident, somewhat confident, not very confident, not at all confident. Our second question, which statement is true about ultrasound for blood clots? It can only detect clots once symptoms are severe. It's a first line non-invasive test for suspected clots in many cases. It's only used after CT or MRI, or I'm not sure. There's only three questions, but make sure you scroll down to get this third one. After today's webinar, how likely are you to advocate for an ultrasound if you or someone you care about has symptoms of a blood clot? Very likely, somewhat likely, unsure, or unlikely. We'll go ahead and give you those results, and then we're going to turn you loose. Julie, that was a fantastic episode. Once again, I
My heart. I'm reading some of the comments in the chat and just
I
full of
know.
empathy for you guys. We're working on it so other people don't have to go through what you all are going through.
Well, and also the cost associated with it. Andrew's commenting on $800. That's just wrong.
Yeah.
You can come to my clinic.
So while we're
We'll
waiting
get
on those results, somebody was asking if this was recorded, and it is. It'll be ready in a day or two. We have a whole library of all of our Pep Talk episodes on the NBCA website. So yeah, be watching for that. So here are the results. After this session, how confident are you in understanding how ultrasound detects blood clots? 65% says very confident, 33% somewhat confident. No one was not very confident, and then only 1% not at all confident. So hopefully they can get some understanding as we go along. Which statement is true about ultrasound for blood clots? It can only detect blood clots once symptoms are severe. 3% check that one. It is a first-line non-invasive test for suspected blood clots in many cases. 93% check that one off. It's only used after a CT or MRI, 1%, and I'm not sure what 3%. Our final question after today's webinar, how likely are you to advocate for an ultrasound if you or someone you care about has symptoms of a blood clot? Very likely, 96%, 3% somewhat likely, unsure, 0%, only 1% unlikely.
All
That's
right.
it.
Awesome. Julie, thank you. You're amazing. Your information and your willingness to share equally is amazing. Thank you for educating us. I feel
Yes.
extremely confident now that if I suspected a blood clot, that I could demand the ultrasound. And worst case scenarios, I'll call you on the phone to help me out as well. So
100%.
thank
I'll
you.
come to my house with my laptop.
Ultrasound parties.
Laptop. Yeah, there you go. Thank you, Julie.
All right. Be well. Thanks, everybody.
Thanks, everybody.